Welcome, everyone, and thank you for joining another virtual presentation as a part of our 2021 Global Health Leaders Conference at Johns Hopkins University program. Today, we're very happy to have Dr. Yukari Manabe at our conference. To briefly introduce Dr. Manabe, she is a professor of medicine at the Johns Hopkins School of Medicine with adjunct appointments in international health and in molecular microbiology and immunology. She is also the Associate Director of Global Health Research and Innovation at Johns Hopkins. She was also the head of research at the Infectious Diseases Institute in Kampala, Uganda, and her research recently has focused on accuracy of testing of various rapid point-of-care diagnostics for HIV and other infectious diseases such as COVID-19. Dr. Manabe, we're very grateful to have you at our conference today. You can feel free to begin your presentation whenever you're ready.
Really great to have this invitation. It's quite an honor, and it's nice to meet all of you. I can only see a fraction of you, but hopefully after I finish my talk, there'll be plenty of time for questions, and then I'll be able to see all of you better. But I appreciate those of you who are on video, because it's nice to have a little bit of an audience. I'm sorry we can't do this in person. It's definitely better. So I wanted to start by talking a little bit about my career, so you could get a sense of the different careers that have happened for different people who are interested in global health. So this is a picture of the HIV/AIDS timeline. And this is really the epidemic of my lifetime. So in 1981, on June 5th, was the first description of HIV in the Morbidity and Mortality Weekly Report, which is the Centers for Disease Control's weekly journal articles. And there they described the first cases of what would later become known as HIV and AIDS. Subsequently, you can see that the gay men's health crisis in New York City got very involved in advocating for particularly gay men who were getting AIDS. And then by 1984 was the description of a causative agent of AIDS, HIV. And then many of you probably are too young to remember the AIDS memorial quilt, but this is something that used to be spread out on the lawn in DC, sort of on the mall. It was so huge that it would take you quite long to walk all the way around it by the time of its last display. In 1987, we got AZT, which was the first known drug effective against HIV. And then subsequently, 1996 might have been the best year of my life as an HIV provider, where we got the triple cocktail, where suddenly people could go from a death sentence to a suppressible chronic illness. By 2001, the UN General Assembly agreed that this was now a global crisis, not one restricted to the United States. And PEPFAR was born under George W. Bush, also known as the President's Emergency Plan for AIDS Relief. And by 2004, the triple cocktail was being rolled out all across sub-Saharan Africa and other countries where HIV was a problem. Became part of the Millennium Development Goals in 2010. And Hillary Clinton, as Secretary of State, declared that we would have an AIDS-free generation in November of 2011. So what's interesting about this timeline is if you superimpose my training, you can see that I was in high school, right, during the description of HIV. And this orange line is when I went to college. The green line was when I went to medical school. And the blue line is when I became a categorical internal medicine resident. So you can see that basically everything in my early training was colored by HIV. And so it's not hard to believe that 10% of my medical school class went into infectious diseases in order to combat HIV. I trained in New York City, and that was really the epicenter. And by the time I moved down to Baltimore to be a resident at Johns Hopkins, it kind of followed me there. So now many of the things that I'd seen in New York City in the years previous as a medical student became my residency experience. And then there was a couple of years where I went and lived on a Pacific island, not to enjoy myself, but to work as a physician. And then from 1996 to 1999, I was an infectious disease fellow. And as I said, 1996, the year of my clinical fellowship, was the year we got triple therapy. And really a remarkable year, a memorable one for me personally. And then this bar, the black bar, as Siam said, I went to go work at the Infectious Disease Institute as the head of research. And why did I go? Why did I drop my basic science career and just pick up and leave and go to Kampala? I did because in 2004, as they were widely rolling out HIV, they needed help analyzing the data to figure out how to institute best practices. And when offered the opportunity to go, as this was the epidemic of my lifetime, I really found it very difficult to say no. So I dragged my entire family. My husband dropped like 18 clinical trials, and we all went together to go live in Kampala. And I will tell you that that was a remarkable experience. Just like in 1996, we watched people who were essentially handed a death sentence rise, gain huge amounts of weight, and come to be very, very grateful for the care that we were offering in the clinic, but often in the health system strengthening programs all across the country. And I'll talk about that a little bit more, but from a tuberculosis standpoint. So today I wanted to talk about the concept of frugal innovation, where you've all heard necessity is the mother of invention. I posit that in fact, scarcity is the mother of invention. And so when you don't have enough resources, how can you make things that are less expensive and accessible to more people? Because of course, access is very key to innovation. So here's a book for those of you that are readers. I'm noticing that people don't read as much as they used to, but many of you read online, you listen to books, you do this kind of thing. So look at this book, E.F. Schumacher's book. It's a little dry, but it's actually very interesting. And what it says is that bigger is not always better, and that what you want is appropriate technology, reduce complexity and cost. And then if you have scarce resources, you can still afford. So you want things that are cheap enough to be accessible, suitable for small scale application, and ultimately compatible with man's need for creativity. So put a different way, if I think about frugal innovation in global health, this is the way I think about it. First, you have a problem, and then you have an idea about how to solve that problem. And then you need multidisciplinary input. You need people with different points of view to give you ideas about how you should solve the problem. Then you innovate, and then you tweak. And the important thing is that you test it in context, and then you reduce the complexity and cost so that you can manage that within the usually limited resources that you might have. So it's very interesting for me, or important for me, to point out why multidisciplinary is important. So if I show all of you this, you see a unicorn, right? And this is the sort of fantastic unicorn that you were shown as a child and was the source of many myths and fables. And it's a beautiful sort of, fantasy-driven horse with a single horn in the middle of its forehead. But if you tell someone like one of my sons is a computer science engineer out working now, if you ask him what's a unicorn, he'll show you something like this. He'll show you an ear of corn on a unicycle. One, because he has a little bit of an off sense of humor, but two, because he's a computer science engineer and he thinks about things differently, right? So now a unicorn can be the thing on the left, or it can be the thing on the right. And the more lenses that look at the same problem, the more likely it is that you're going to come up with frugal innovation. So I'm going to give you an example in the field of tuberculosis. Some of you may find this to be difficult to grasp because you don't know much about this disease called tuberculosis, because in the United States, we don't have very many cases, maybe 7 per 100,000 people. But in places like Kampala, we have 300 to 400,000 cases, or 400 cases per 100,000. So about half of a percent of the population will have TB in any given year. Huge amount. So the important thing is, how do you come up with frugal process innovation? Not just technologic innovation, but how can I change the process with scarce resources to be able to solve the problem of TB? So the most important thing is that you have to find the TB patients, right? If you don't know who they are, you can't treat them. But finding a TB patient has very many steps. And when you break it down, this is called a process map. And so I make a process map. First, I need to identify TB suspects. What does that entail? Well, first, I have to get qualified providers, right, who can recognize people with TB. I have to then train them to recognize TB. And for a long time in places like Kampala, who was being trained? Doctors. But doctors half the time didn't go up country to rural areas because they wanted their children to grow up with all the amenities of the big city. So they would go to the courses, they would get their per diems, they would go to a nice hotel, they would hear all the things, but they would never cascade down to the people who were actually at the site seeing the patients. So we often found that they couldn't really recognize TB, the nurses and the sort of clinical officers. The next thing is you have to do a test, right? So that test used to be what we call a smear diagnostic. You cough into a cup, you smash it out onto a slide, you dry it, you stain it, you read it, and then you decide if the person has TB. Not the most sensitive, but definitely can be done almost anywhere. So what do you need to have that work? Well, you need a functional lab, you need space, you need electricity, because microscope usually takes less electricity, although you could just use light, ambient light. Reagents, again, qualified staff who can read the slide and know exactly what a TB bug looks like. And then someone has to do quality assurance, quality control on that. That's a lot of steps. Then you have to return that result to the patient. Say it comes back positive. You have to give that result to the person and tell the person, come back, I need to see you, we need to assess you again, and then we're going to start you on therapy. So first the patient has to return. You need records that say where the patient lives, right at the mango tree, left at the borehole, right again after the second cassava plantation, and then that's my house, right? So someone has to find that. And then you have to keep records, and then you have to link what the lab said to a clinical record, and that often doesn't happen. Finally, you have to treat the patient for 6 to 8 months. You need good staff to do that. You have to recognize side effects, and you need good linkage to national programs, and the drugs have to be available. That is all the steps that's required from suspecting that a person has TB, diagnosing TB, all the way to treating to completion. So herein you see the problem. TB magnifies health system shortcomings. And because you need so many things to work to make tuberculosis come under control, you can now see worldwide why we have so much TB. So this is the Infectious Disease Institute where I went to work. Over here on the far right, you can see the view of Mulago Hospital. I don't know if any of you have seen The Last King of Scotland, but you will see this hospital come out when you watch that movie. This is from the roof of the medical school, and over to the right, you can see the Infectious Disease Institute. On the bottom, another picture. This was opened its doors in 2004. These are 3 of my mentors that helped me get there. Actually, they have 5 major programs and about an $80 million annual budget. This place is doing fine. So I next wanted to talk about the Millennium Development Goals. This happened, I showed you on that first timeline, during my tenure there. The Millennium Development Goals were outlined, and you can see here, combat HIV, AIDS, malaria, and other diseases. And so combating TB was very much at the WHO and the UN's mindset to really control TB. So this was an important problem, and we needed to come up with a solution. So we decided first to start with a research project. We got some funding from the WHO in this thing called the Stop TB Partnership, TB Reach. So you see all of these different pink areas. These are the 10 districts where we decided to work at a regional, health center 4. So this is just below a regional referral hospital and a tertiary referral hospital next to a health center 4. There were 10 of the pink ones where we did the intervention and 2 controls that would have the red boxes. The idea was to improve case detection and to standardize case management among underserved vulnerable populations using best practices models developed at the IDI. And the most important thing is that it was multidisciplinary training. We didn't just train the doctors, we trained the lab techs, we trained the clinical officers, we trained the nurses, all of the mid-level providers that you would find at the health center. We supervised on sites. We came back and said, this is what you're doing well. This is where you could improve. Look at your data. This is what we think. And importantly, I told you, we included the lab and we strengthened the lab. And why is that? That's because this is the first rule of global health, is win-win or walk away. Remember, people are busy. There's a lot going on. And so if you can't find the win-win, Win neutral is not good enough. You both have to win somehow. Otherwise, you should walk away and part friends, because otherwise you're wasting resources on your project, which really isn't a win for the people with whom you're collaborating. Often I'll have a stakeholder meeting to begin with to really identify what the win-win is. I might think this is a good idea, but again, input from a lot of different people so that what you come up with, they feel equally vested in the outcome as you. And if you decide you're not going to collaborate because you can't find the win-win, then part friends. Say, I'll come back together with you now that I know what you need. If I can find such a thing, then we'll come back in the future. And so we did that. We came up with microscopy training. They said, you know, Dr. Yuka, it takes too long to look at a slide, 5 to 7 minutes per slide. Give us a way to look at slides faster so that we can increase the number of slides we see tenfold. So we did that. We gave them fluorescence microscopy that takes about 1.5 minutes as opposed to 7 minutes. And again, we trained them on site because they didn't have time to leave. Who was going to see the patients while they were not there? So this is the win-win or walk away. I'll put these little movies. Some of these movies are very old, so I'll be very impressed if any of you high school students have ever seen these movies. So put in the chat if you know what this movie is and see if you can impress me with your knowledge of old movies. But this is a movie where 2 men who are single skaters end up skating together because that was the win-win. It's kind of a funny movie. It's like the kind of movie that boys like. So I have all boys. I have 4 boys, so they love this movie. So this is the kind of setting that we worked in. Here's one of our TV Reach team members who is teaching all of these people in one of the multidisciplinary trainings. And this is one of the places way up in the north, right next to sort of the refugee centers that borders on southern Sudan, as well as the Democratic Republic of Congo. So what happened? I don't know how much you guys look at graphs, but here on the x-axis, we have the 4 quarters of the intervention centers and the 4 quarters of the control centers. Along the y-axis, you can see the proportion of TB suspects that were screened. We aimed for a target of 70% of the people that I looked at the chart and I saw the criteria for needing a TB smear, they got a TB smear. So we wanted 70% of the time that to happen. So you see here in the first quarter, only 13% of the people that I would have estimated needed a smear got a smear. That's terrible, right? Not close to 70%. And as the quarters went forward, you see by the end of our intervention period, we achieved 83% of the people that we thought needed. Oh, very good. You guys are good. Blades of Glory. How did you watch that? That's good. I was not expecting that. I thought none of you were going to know Blades of Glory, but fair enough. Okay, so here we are at 83%. By the end of the last quarter, which is way over our target of 70%. And you see what happened here in the control centers. But importantly, if you look here, the number of smear positive TB patients in the blue bars, the beginning we found 18 in the first quarter, and by the last quarter, we found 161 patients at the very same health center, just because they were screening more so they could find more. And then these are people that were treated to completion. So they made it along the entire pipeline of the process map that I showed you. And look here what happened in the control centers, 2, 13, 18, 16, not much, right? So this I think is great. 186,000 people were screened in outpatient. There was a 12-fold increase in TB sputum smears, and so we had equipped the lab to be able to handle this more than 10-fold increase, which we had predicted. And then we had an almost 5-time increased number in the smear positive patients that we were able to find and treat. So rule number 2, under promise, over deliver. This is not just a rule of global health. This is a great rule because remember, when are people the happiest? They are happy when their expectation is met by reality or exceeded by reality. So if you under promise a little bit, and you over deliver, then everyone's always happy because they were only expecting this and you delivered this. So keep that in mind. Don't bite off more than you can chew. It's always better to surprise your partners with more outputs than to promise the moon and give them nothing. So set achievable targets. This is a really important thing for you to remember in life as well. Don't tell your supervisor, yeah, I'm all over that. I'm going to write that paper. I'm going to get all that data. I'm going to do 60,000 experiments. And you have really no intention of doing any of that. Under promise, over deliver. So we had been asked to bring molecular diagnostics, the expert, to all of these sites. And we knew that some of them didn't have electricity. We had to put in solar panels. It was a hassle. So we said, we're going to do FM microscopy. And if maybe we'll do expert, but we don't think so. We brought expert to all of the health centers in a hub and spoke system. And we found a lot of those cases using expert, but we didn't promise that, but we over delivered. So here's the TB Reach team. I just want to show you the people that did the work. And the person that I particularly like to point out is here, Dr. Stella Muyanja. Stella's a great friend, one of the best implementers I've ever worked with. So rule number 3, pick your battles. You guys have to know. Oh, you didn't tell me what the other one was. Do you know what the other, you didn't put in the chat what you thought the under promise over deliver movie was. And then you can also put this one in. I don't know if you know who this guy with the blue and white face is here, but pick your battles. And the reason I say this is sometimes it's better to lose in some, yes, that guy is William Wallace, well done. So it's better to lose a little and still be able to accomplish something than to fight over something small and lose everything. This is a really important point. You know, decide where you really want to throw down the gauntlet. Don't do it so easily. Make sure that it's something you really care about. So the Ministry of Health, despite our urging and despite them being involved from the very beginning, did not want to adopt our intervention. So of course we were disappointed. But what we decided to do is we scaled up our intervention within the Infectious Disease Institute Health System Strengthening Department, what was formerly called Outreach. So we thought, well, this is a good place to start. So here's a case history of the TB cascade of care at the IDI. So here we have TB Reach. Its predecessor was IDCAP that taught us about training on site. So we incorporated that into TB Reach and it morphed into something called TB Mentors. But these 3 streams of funding led to the iterative improvement of the idea to solve the problem of finding TB patients. So what was our package? Well, I kind of told you most of this, so I won't go through it again, but this was the package that we put into place in the districts. So what happened? If you look at this data, you can see in the far upper right-hand corner here, the shaded districts in this black map are the districts that IDI covers. The data to the right of that is the data from the Ministry of Health, again, of Uganda. And you can pick out the districts where IDI works. And what you'll see is that our districts went yellow and green when they started out as largely red. So we went from 41% of TB case detection up to 59% in the Midwest region. We went from 45% to 54% in the West Nile region. And this continues to improve. And this is really what happens when you take an intervention, you've worked it out by research, you trim it down, and now you put it in 18 districts, and most of them go yellow and green. There's one district here that stayed red, you'll notice, and that's because that was right next to Lake Albert, and those are all fishermen, and they are often not there. So they get diagnosed, and then they go off fishing, and then you can't find them. So that turned out to be a difficult problem. So migratory populations are very difficult with TB. So research to training to outreach. And interestingly, in that last year, 61% of TB training was actually done by the Infectious Disease Institute countrywide. So most of the training that was happening in our 18 districts, showing that very little was going on in actually many of the other districts. So here's rule number 4. Here's another movie for you. This is a good one. If you build it, they will come. So what does that mean? No one wants to give you money when you're like, I have a great idea, you should fund me. That is not, yes, Field of Dreams. And it is, I don't know if he was supposed to be Babe Ruth, I can't remember now, but I think that's right. No one wants to fund something that isn't something. So, you know, you ask someone to fund something when you have absolutely nothing built. We built our first TB clinic with one of those pop-up tents, and then rainy season happened and then it blew away. But my director could see that we were serious, and he helped build us a lean-to. And if you were to see the clinic that started out as a pop-up tent today, you would be amazed. So that's how you build. You create something and then make it bigger and bigger. So expansion of this intervention worked, the scale up worked. And then rule number 5, the last one I'll show you, is listen more than you speak. There's a an aphorism in Africa that says, God gave you 2 ears and 1 mouth for a reason. So you should listen to your collaborators and your stakeholders in order to do relevant research that affects lives. So IDI now is in charge of Karamoja districts. You see this very, very, very red area up here. This is where the cattle pastoralists work. This area has been difficult from a TB perspective for a very long time. So good deeds are often rewarded with difficult work, but this is what's happened, and IDI has gotten a sizable amount of money to try to solve the problem of migratory populations. So I like to show this because I think I've always liked this Chinese proverb: those who say it can't be done should get out of the way of those doing it. So don't just listen to the naysayers, try to come up with a good idea, talk to all the people that you work with, to the stakeholders, and see. And if you can't come up with the win-win, then walk away, but otherwise go ahead. So I wanted to finish up with the concept of frugal innovation. And I wanted to bring up the microscope. So back in the 1600s in the Netherlands, or also known as Holland to some people, one of the bigger regions of the Netherlands is Holland, von Leeuwenhoek came up with the microscope. I'm sure all of you learned that in high school. And then his was a single lens microscope. And ultimately it became a double lens microscope, and here's the handheld version. But ultimately it hasn't changed a ton, right? The microscope we use today is not so different from the one that von Leeuwenhoek used in the 1600s, which you would think that that would be enough time, 400 years, for us to come up with something new, but we really have not done so much. So here is Dr. Manu Prakash. He is an investigator at Stanford. He worked with a PhD student at that time, Jim Cybulski. This is a while now, maybe almost 8 years ago. And he came up with a paper microscope that he called a Foldoscope. So you can see him holding in his hand this piece of paper. And that paper has everything in it and the instructions for you to make an origami microscope. The most critical part is here. You can see this little kind of hump. This is a crystal that allows for the lens microscopy to create that magnification. And so the COGS, or the cost of goods, is actually quite low. He likes to say it's 50 cents. It's probably a little bit more than 50 cents, but he can print many of these and then embed this small crystal. And then the instructions are on there. So the way it works is, and here is Manu showing everybody how his Foldoscope works, is there's a light inside that's battery operated, and you can like push on it on either side to focus and make the focal length right for whatever you're looking at. You stick the slide in and then you push up and down, and then the image can either be shown or you can look at it yourself. So I think that this is really cool. And this is he gets everyone excited. He's a great speaker. And I see in the chat that he's going to be there on the 26th. So he has made this really cool centrifuge. I think he's the new Einstein. I think he has great ideas, and he embodies frugal innovation. Here's some pictures that you can see with his microscope. And finally, I love to say that you should be able to make one of his microscopes, because this small child is making one of his microscopes. Not difficult. And his idea is that every kid should have access to a microscope. Usually they're just locked up behind a cabinet because they cost so much money. But if the thing costs 50 cents, they can be left out so that people can actually benefit from them and use them. So there's many, many great things. And the paperfuge is yet another one of his inventions. So I wanted to end with the Center for Innovative Diagnostics and Infectious Disease. Many of the things that I learned in Africa, and I learned from people like Manu, really led me to think that we should be bringing some of this innovation to diagnostics. And so we created what I call the CID squared. The mission was to develop accessible infectious disease diagnostics through multidisciplinary innovation along the development pipeline, from basic research and development, proof of concept, accuracy testing, all the way to assessment by the FDA. and or the WHO, and that it could have impact in many, many settings. And so our vision, you have to come up with a quick vision statement to accelerate improvements in global public health through infectious disease diagnostics. So I show you this because some of you are going to be in charge of something. Come up with a mission and vision that you can get behind that really states what it is that you want to do with your life and with your effort in this area. So here's an example of what we did with the point of care technology, the Center for Point of Care Technologies Research for STDs. This is funded by the National Institutes of Health. And this is the pipeline that I was talking about. And many of the things that we've done have been very impactful. We've been able to get dual testing for pregnant women for HIV and syphilis. We've started gonorrhea surveillance programs in places like Uganda. We've gotten FDA approval for some rapid point of care tests for gonorrhea and chlamydia. And we've also been able to have online innovation with I Want the Kit, where you can just sign up online. We'll send you some swabs, you collect them yourselves, and we'll test them, and they're for free for gonorrhea and chlamydia. And this is our contribution to trying to decrease the burden of sexually transmitted diseases. But then we said we were working very happily in the area of STDs, and then what happened? SARS-CoV-2 and the COVID-19 pandemic. And so I like to say, just as Louis Pasteur said, chance favors the prepared mind. And so we took our point of care center, and along with 3 other centers within the network and the CIMMIT coordinating center at Mass General, the NIH asked us to take $1 billion and try and accelerate diagnostics for COVID. Now, the cast of characters that have played a part in this play are many hundreds. So our center was one cog in that wheel, but one that we're quite proud of. And I think this is an important thing where you're doing something in one area, you can translate what you know into another area. And I think the CID squared was well placed to do that. Now we not only work in the area of COVID and SARS-CoV-2 detection, we do STDs, we do HIV, we do other respiratory viruses, neglected tropical diseases like Chagas, sepsis, and acute febrile illness. So many of the investigators at Johns Hopkins are now working really virtually with this center. And I think it's an example of how you can take a focus around one set of diseases and magnify that and have a bigger effect on more diseases, as long as you can stay close to your strategy. So here's a picture that I took off of the balcony of the Infectious Disease Institute the day I arrived, and I saw this big rainstorm came through, and I saw this double rainbow, and I thought it was a good omen for things to come. And in fact, it was. It was 5 of the nicest years of my life. I really felt it was productive. I worked with wonderful people, and I still work with the Infectious Disease Institute. I understand. So I want to leave you with this aphorism: life is not about waiting for the storm to pass, but learning to dance in the rain. So with that, I would be happy to take any questions from you. I will stop sharing, and I look forward to seeing all of your faces.
My name is Felipe. I am a rising senior in Las Vegas, Nevada. I go to East Career and Technical Academy. Dr. Manabe, I just wanted to thank you for speaking today. And my question to you was, obviously, working in a different country, in a different region, how did you work in conjunction with the local government to kind of and help your initiative?
So the Infectious Disease Institute, when I moved there, had only 4 expatriates. The rest of the people that worked at the Institute were from Uganda. And a few of the expatriates that I mentioned were from other African countries. So in general, it was an Indigenous institute, and it was viewed like that. So that's helpful, right? Because the Institute would often meet with Ministry of Health and try to make sure that its strategy was aligned with the strategy of the Ministry of Health. And I think that's really important. It also assured that everybody that was working with the ministry was culturally competent. It was their culture. So one of the hard things sometimes about going and working in another country is that you have to find out what the cultural norms are in that country. I'll give you a maybe sort of an unimportant but also important example. So in Uganda, if 2 people are speaking and there's no way for you to pass without walking between them. You have to stand there until they're finished and they let you pass. Because if you walk through, it's considered very, very rude. Now in America, I can say that that happens all the time, right? You see people walking right through people's conversations and they wouldn't think that that was rude. And I think it's really important. It's not a very big example, but it's an example of if you didn't know that, a lot of people might think you're very rude if you were constantly doing what you do in the US, in Uganda. So I think you're right. We not only worked closely with the Ministry of Health because that was important to us, but we also, and because it was an Indigenous institute, but we also, as a person who was an expatriate, I thought it was really important to spend some time talking to other people about what the cultural norms would be.
Hi, I'm Alex Lamoth, and I'm a rising junior, and I live in Phoenix, Arizona, and I go to Base Sawatuki. My question is, since you have seen diseases and epidemics both as a teenager and working in the medical field, what advice would you give us and doctors given the pandemic we live in right now?
Yeah, so I think COVID-19 is going to be the pandemic of your lifetime, right, Alex? I think that it will probably, without you knowing it, color very much of the way that you look at things in the future. When things are starting to open up now, I'm sure that you think that you compare and contrast to how it was just a year ago and think, wow, I'm so lucky I get to see my friends. I can hug my relatives. There are many things that are different. And so it will not, I'm sure that many people, hopefully, I hope, will go into infectious diseases. This is not going to be the last. We've had continual outbreaks. You all remember we had Ebola not just a few years ago. While I was on the ground in Uganda, we had a botulism outbreak. We had a Hep E outbreak. We had 2 Ebolas and 2 Marburg outbreaks. We had a Crimean Congo hemorrhagic fever outbreak. There's a Rift Valley fever outbreak in animals. It's kind of constant. And I think that it's, as I said, chance favors the prepared mind. If you make the systems to detect things early, you can really cut down on the morbidity and the mortality that occurs as a result of an epidemic. I would also say to all of you, though, that if it feels right, seize the day, right? So you all say carpe diem all the time, but you really should seize the day. Many people thought I was crazy to go to Uganda, drop everything I was doing at the bench just to move there, but it felt right. And so I did it, and I don't regret it at all. Similarly, when I moved overseas to be on this island, I wanted to stay with my husband. We had 1 small child at the time, and so he got stationed in Guam. So I went with him and I did general medicine. I saw so much great medicine, and I became a greater doctor for having done it. So sometimes when other people might say you're compromising, if it feels right for you, seize the day.
Hi, I'm Jayla. I'm from Solon, Ohio. I'm a rising sophomore, and thank you for giving your incredible presentation today. I wanted to ask, so often when I hear about problems in sub-Saharan Africa with in the medical field is because a lot of people don't have access to proper medicine. What's the greatest barrier keeping us from expanding like hospitals to different areas in Africa right now?
Thanks, Jayla. I mean, I have to say that prevention, there is an ancient Chinese doctor who like 1,000 years ago said that inferior doctors treat disease when evident. Mediocre doctors treat disease just before evident, and superior doctors prevent disease. And so I think that in resource limited settings, prevention is the most important thing. Vaccines have saved millions of lives. And vaccination, you know, you guys didn't live in an area where diphtheria epidemics happened all the time. You don't remember what it was like when everyone feared polio. Now you have a chance to prevent cervical cancer by getting HPV vaccine. I mean, there's so many examples. And this last year brought the unprecedented pace of vaccination with COVID-19 vaccines. which you all know generally take years to develop. And in this case, in a year, we had 3 viable vaccines that were already being manufactured while they were being investigated, which was what allowed this to happen so quickly. Of course, it was money as well, but prevention is really important. So for those of you interested in public health, I would really urge you to consider some of the great innovations in the past 300 years that have had to do with prevention, right? Putting clean water far and away probably prevented more disease. So the pump, right? The borehole, not just using groundwater, that kind of thing. So I encourage you to think about that. Prevention. How can you prevent the thing from ever happening, create the health systems that allow more people to be healthy?
Hi, my name is Siam. I am a rising sophomore, again, from Solon, Ohio. First of all, thank you so much for your presentation. It was very eye-opening and insightful. One question I have is, first of all, like you emphasized a lot about cooperating with and working with others that had like different perspectives, and working with like stakeholders and people who were supporting you. And like I really like the unicorn example. I think that's very nice. But one question I have is, how do you deal with disagreements that can come up from like the presence of different perspectives? Like one example being, for example, COVID-19, like the present pandemic, when a lot of health leaders were, I don't want to use this word, but almost like clashing with the perspective of the government when they thought a lot about like the economy.
Yes, Iram. So remember, data is your friend. So you have to work really hard to gather data. And so from my perspective this year, I spent a huge amount of time not only trying to read the existing literature as it came out, which was thousands of articles around SARS-CoV-2 diagnostics, but also making sure that every time evidence came out, I tried to apply that to what I was doing. So we went wrong, I think, in the US when we ignored the evidence. And sometimes evidence changes. So early on, I don't know if you guys remember, but everybody didn't want to bring their groceries in and they wanted to spray everything down and leave their mail out in the garage for a day or two. And now we realize that probably was not very important in terms of transmission. The transmission was happening during SARS-CoV-2 superpower time, which is when you have asymptomatic infection, but you have a lot of virus. And then you go to things and you talk and speak and in poorly ventilated spaces and you give the disease away. And that was very different from SARS-CoV, the original, where really people transmitted mostly when they were symptomatic. But once we found that out, we should have really shut down everything, right? We shouldn't have had indoor dining. And also the evidence around masks was available very early. Just masking alone, if we could have gotten everybody to embrace that, that was highly politicized when it really didn't need to be. And so countries that did good masking before the variants did much, much better. So be guided by the evidence and read the data and be willing to change your mind and say when you were wrong. And admitting that you were wrong and then changing course is worth a lot. I think people that do that have great integrity.
Hello, thank you so much for your presentation. I really loved your personality and how you presented it with life lessons. And I'm Nahar, a rising sophomore from Atlanta, Georgia. And I wanted to ask about, so in what I saw that many of your interventions were based on simplicity and the main focus was just being efficient and not complex. But is there ever a point where we need more high tech as opposed to something simple? And how can you differentiate between what type of approach to take in certain situations in epidemiology and preventing disease?
Yeah, that's a difficult question, a very good one. I always wondered why so many inventions in time have occurred simultaneously by multiple people. So for example, HIV was discovered by 2 different labs at exactly the same time. It turns out that when Edison discovered the light bulb, there were patents for similar things from 5 other people. Thomas Edison just managed to get across the finish line, but other people thought the same thing. So there's something about the context also of when people are making discoveries that are important, right? It's the sequential nature of discovery and of everybody reading that brings many people to the same conclusion. So whenever you have a great idea, you can be assured that probably there are other people across the globe that are having the same idea. But it's those who have the tenacity to get across the finish line that matter. So it doesn't always have to be simple or cheap. It's good if it's cheap because then a lot of people can benefit from it globally, but it could be more expensive. It's just a matter of being able to make it across the finish line. And many in vitro diagnostics that I work on don't make it across the finish line because they're too complicated. They try to slam too much into a small space or do something in a way. So, you know, sometimes you're told in grade school to make a more complicated machine when a simpler thing could do, right? Everyone does that as an exercise sometime in high school. I had this really great French collaborator named Jacques Rosset, and Jacques said, why make it simple when you can make it complicated? And, you know, I think he's exactly right. Like, that's what people try to do. So my advice to you is if you can make it simple, make it simple. Sometimes you need to take advantage of where things are, right? Remember Moore's law, where they tried to get more and more transistors onto a smaller and smaller space onto a silicon chip, right? And there was a limit to that. But that doubled every 2.5 years or something until we saturated. But yeah, some of it's context and some of it's complexity, but when possible, I do think that if you can make it simple, it's usually more likely to get across the finish line.
Hello, I'm Andrew Bogus. I go to St. Albans High School and I'm a rising senior. I wanted to ask if you ever have to worry about carrying over diseases from your own country when you're going to another country.
Yes, definitely. I think that I think it would be great if people always wore masks during respiratory season. I think that if we all masked this fall, we're going to have a lot less influenza. So in the state of Maryland, I think we had like 2 cases of influenza. We got more once people started unmasking. So we had that late peak that we always get sometime in the April timeframe. But it's really interesting. We got very little this year. There's a lot less RSV in small children and babies because people social distanced and masked. So yeah, you don't know what you're carrying from one place to another. The globe has gotten very small. It's not my favorite movie, but there's some interesting things about that movie, Contagion. But one of the things that I found most interesting, where it was like that woman started in Hong Kong, and that's what happened with SARS. What she had was sort of like Nipah virus, which I think could certainly is another one that people worry about as becoming an emerging infection. I have to say, if I can encourage any of you to go into infectious diseases, we desperately need people to want to do ID. And I think it's because of this, like it's always changing. You'll never regret the choice. It's like, you know, microbe hunters. You get to keep figuring out stuff and it's always changing. You'll never be bored. But you're right, absolutely, Andrew. I could carry things there. I could carry things back. And so I had a trip planned actually to go to Kampala. Siam knows we had a little bit of trouble figuring out a date for this talk because I was supposed to leave on Tuesday to go to Kampala. It's going to go for 2 weeks. And I've canceled my trip. They're having another wave. I think they're having a lot of Delta variant. And I would hate to bring that back. Even though I'm vaccinated, it's possible that I could have low-level asymptomatic infection. And I've decided to postpone my trip. I'd also potentially force a lot of my friends and colleagues to come see me in person on the roof of some building unnecessarily. Why should they take the risk? And why should I be part of the problem? So I canceled my trip.
Hi, my name is Gabrielle, and I'm a rising senior from Chicago, Illinois. Thank you so much for your presentation. It was very insightful and interesting. I actually had a question about the role that you were mentioning as a part of infectious disease, studying infectious disease and life in general. One of the rules was always settle for win-win, and then another one was picking your battles. Do these 2 rules ever contradict each other? And how do you know when you're picking a battle that's too big, a battle that will result in like a win or neutral? What do you do in those type of situations?
So I think part of it's open communication. I think that many of you have probably experienced this in high school. High school, when you're given an assignment, you're given a rubric, right, by which that assignment will be graded. I don't know, most of you are shaking your head. So you know what your teacher's looking for before you start, right? So you try to conform. And most of you want to be in the conform column. You want to do what's right. And I think that that you don't want to pick fights with your teacher, right? Like that's what you're taught. You just conform and do what you need to do. But sometimes you also have to stick up for what's right. So I agree, sometimes you have to pick battles because you're sticking up for what's right. But I think that if you spend a lot of time listening to the people that you're working with, most times you're going to start to suggest solutions that they're going to find very palatable. So I often say, when you're somewhere new, spend a lot of time listening and reading body language and seeing where people are. And so that really picking battles is the least of what you do, and more of what you're doing has to do with crafting the win-win. So yeah, 2 ears, 1 mouth is probably the way I would look at that. If you have a moment, I want to just show one thing. I want to leave you all with a poem. You've already figured out I like movies. I think that's why I do global health, so I can fly around on airplanes and watch things on a really tiny screen, but I'm quite caught up. But the last year has really impaired my ability to stay on top of movies. But I'm gonna show you one poem that I hope is one that might resonate with all of you, and hopefully will be one that you can live by. So this is a poem that was originally written by Kent Keith and is supposedly in Calcutta on the wall of Mother Teresa's orphanage. And it says, "People are often unreasonable, illogical, and self-centered. Forgive them anyway. If you are kind, people may accuse you of selfish, ulterior motives. Be kind anyway. If you are successful, you will win some false friends and some true enemies. Succeed anyway. If you are honest and frank, people may cheat you. Be honest and frank anyway. What you spend years building, someone could destroy overnight. Build anyway. If you find serenity and happiness, they may be jealous. Be happy anyway. The good you do today, people will often forget tomorrow. Do good anyway. Give the world the best you have, and it may never be enough. Give the world the best you've got anyway." So with that, I'll close. I really enjoyed being here with you today. I wish all of you the best of luck. I hope that all of you see brighter times moving forward. I'm sure this year has been really challenging. My last child graduated high school during COVID, and I felt bad for him. His life was just not the same. And this year, first year of college, has been really challenging. So believe me when I know what a difficult year it's been for all of you. I do think, though, you should set goals for yourself and try to achieve them, and do them despite the storm that was brewing in this past year. Know that you can make a difference, and I hope to see all of you and your names in lights in the future. So thanks.